Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. It's such a great pleasure to have you all on this activity and specifically this webinar, The Road to Trauma-Informed Care in Primary Care. We are very pleased to have two excellent panelists. And this is a topic that is very important for all health centers, and specifically for those health centers located in or immediately accessible to public housing. The National Center for Health and Public Housing is funded by HRSA to provide training and technical assistance to health centers, and specifically to the health centers located in or immediately accessible to public housing. We have three divisions: the Training and Technical Assistance Division, the Research and Evaluation, and the Outreach and Collaboration sections. Before we get started, we are going to have, at the end of the presentations, our question and answer session. So everybody will be muted, and if you have any questions, you can use the chat box, or you can use the raise hand icon and ask your questions. There are, in general, around 1,400 community health centers across the nation, and 385 are health centers located in or immediately accessible to public housing. 107 of these health centers are public housing primary care grantees, and in 2018, they provided services to over 800,000 patients. So before we hear from our panelists, we have some questions. The first question is, have you adopted trauma-informed care approaches at your health center? So we're gonna open the poll and we are going to give you 30 seconds to respond. All right, Fide, can we see the responses?
Yes, 48% is yes, and 53% is no.
Okay, 53% is no. All right. For those who answered no, are you planning to adopt a trauma-informed approach in your facility? All right. Can you please close the poll and see the responses?
90% said yes, and 10% said no.
All right. And for those who answered yes, do you see any major challenges to sustain your trauma-informed care measures in your facility? All right, Chantel, please close the poll and let us know the responses.
65% of participants voted yes, and 35% of participants voted no.
Excellent, thank you so much. So this is a very good opportunity for everyone to learn from the National Council and Zufall Health Center about what they are doing to address this very important issue. The first subject matter expert that we are going to hear from is Sharday Lewis. Sharday serves as the project manager of practice improvement, where she manages multiple national council initiatives in the area of trauma-informed service and SBIRT. Prior to her work at the National Council, Sharday worked at the Miami Coalition, where she oversaw programmatic operation of a 2-year SBIRT project targeting adolescents. Additionally, she has spent 5 years managing national trainings for the CDC's High Impact Prevention Project. She holds a Master's of Public Health from the University of Albany School of Public Health and a Bachelor's of Science in Health Management from Howard University. She's passionate about social justice and advocating for vulnerable populations, most specifically adolescents, wellness, and the elimination of health disparities resulting from racism, classism, and other systems of interconnected oppression. Second, we are going to hear from Kathy Orchin. Kathy has been dedicated to healthcare delivery for over 40 years. She worked most extensively with limited resource populations in the development and implementation of enhanced health and nutrition services. Currently, she is the Quality Assurance Program Manager for Zufall Health Centers, a federally qualified health center serving over 38,000 patients in Northwest region of New Jersey. Her commitment to quality healthcare has spanned from rural populations to inner city residents in America's most challenging economic environments. In addition to her professional work, Ms. Orchin is presently enrolled in the Conflict Resolution and Negotiation Masters of Science program at Columbia University and interested in the relationship of trauma, conflict, and health. Without further ado, I will turn it over to Sharday. Good afternoon, Sharday.
Thank you, Dr. Yoon. So thank you, everyone. I'm excited to speak with you all about our trauma-informed primary care initiative. So just to get us started, we'll get us started very high level with some objectives or sort of an agenda for our time together today. And what we're really here to do is discuss the National Council for Behavioral Health Trauma-Informed Primary Care Initiative, and then review the change package, which is the tool that was developed during that initiative as a tool for driving trauma-informed primary care implementation. So before we go any further, I just want to make sure that I'm acknowledging Kaiser Permanente. Our project work on the Trauma-Informed Primary Care Fostering Recovery and Resilience project was generously funded by Kaiser. We've been working with them over the last 3 years, and we could not be more excited to really release this new product to the larger field. So I just want to start out by giving you a little bit of background on the Trauma-Informed Primary Care project. Over the past 3 years, this journey has really involved a collaborative and inclusive process that focused on developing, testing, and refining our change package. And that's really focusing on sharing best practice information, expertise, and knowledge learned on the ground between our primary change agents and our practice transformation team and learning community. So ultimately, the project can be broken down into 3 phases. The first phase, we convened a practice transformation team in the summer of 2017, and with them, we worked to develop change package content over the course of about 10 months. After that, we convened a learning community, which started in August 2018, and that was with 7 diverse primary care agencies to really test the efficiency and the effectiveness of the change package. And then phase 3, which is where we are now, is we are refining the content based on our lessons learned and disseminating to the broader healthcare field. So I just want to give some quick background on who the practice transformation team was and what their role in this process was. Their primary purpose was really to identify and create the content and lay the foundation for the guidance and the methods and the tools that would ultimately become the change package. They met in person to develop agreed upon aims and drivers. They unpacked practice challenges and barriers and really highlighted best practices to build the change package guidance upon. In order to drive content development, they also broke into kind of virtual work groups to engage in smaller group discussions around particular elements of the change package that they identified as critical. And that's really how, again, we drove content development. So another key thing to highlight here is that we really focused on making sure this practice transformation team was a very diverse group of experts. So we had leaders from primary care, we had participants from past learning communities, we had safety net representatives, researchers, and educators. It was really important to us to have a wide net and a really diverse set of perspectives at the table as we sat down to really codify some of the core components of trauma-informed care implementation. So before we go any further, I've been using the terminology change package a lot, and I want to make sure that we're kind of level setting and all on the same page about that. So a change package is really just a practical toolkit. It outlines an evidence-based set of changes that are critical to the improvement of an identified care process, and what kind of differentiates it from a normal toolkit or a toolkit that you might see more traditionally is that it really kind of includes these change concepts, which are things that marry clinical implementation guidance with operational changes, but they're still kind of generalizable enough to be scaled in multiple settings. And change packages have been proven to be really effectual tools to actually practice change, especially in primary care. There were several change packages around depression and other kind of core clinical processes that have worked in primary care. So what does a change package look like for primary care specifically? It kind of outlines agreed upon trauma-informed care components. There's information on screening and response processors, outcome measures, trauma-specific interventions, and other implementation practices to ensure that your implementation is evidence-based, scalable, and sustainable. So I want to go through the package of the framework of the change package quickly, just noting that it opens with a brief introduction on why to implement trauma-informed approaches in primary care. There's some talk about what is trauma and what is resilience and what is a trauma-informed approach and its principles, just to kind of level set. And while it is also really important to kind of prioritize and implement components of the change package based on the results of an organizational self-assessment and other internal and external priorities and market influences, a real key differentiator of the model that we've created is a recommendation to address change management first in order to create the optimal conditions for change. So this looks like things like convening a core implementation team to drive the work, administering an organizational self-assessment, raising awareness and communicating about the prevalence and impact of trauma. After some of these foundational change management strategies have been adopted, then the framework moves on to include 5 trauma-informed areas of action, which I'll talk about now. So these 5 change concepts are really a simplified version of the principles of trauma-informed care that have been distilled down to the levers that will actually drive an actually implementation. And this list was really conceptualized by that practice transformation team that I talked about earlier. So a couple of things to highlight here is that the 5 change concepts are generally addressed in the order that they're presented. However, it is unlikely that an agency would complete one full step before they move on to others. This is really a multi-step process that is implemented over time. So some action steps in one change concept can influence action in another, and agencies just kind of have to balance that, but it's really important to kind of understand that going in, that it's not like you start with change concept 1 and then you do all the things in change concept 1 before you move to change concept 2. There's a little bit more interplay there between the change concepts. Another important thing to note here is that there are 2 change concepts that focus on staff specifically. And while we often think about the impacts of trauma-informed approaches and what that will do for our patients and our clients, it's really important to note that trauma-informed approaches bring in critical opportunities for increasing the way that you support your staff, increasing the way that staff are engaged in work, and then consequently enhancing the types of output and satisfaction that your staff is experiencing. So that is just to stay high level. We'll get into a little bit more of the concrete items within the change package later, but I just wanted to start out by providing a skeleton or a framework for how the information within the change package is organized. So moving on to the phase 2 of our trauma-informed primary care initiative, we released a competitive RSA to solicit sites to test the change package. It was really important to us that we had all of these really smart minds around the table conceptualizing guidance for a toolkit, but we wanted to make sure that it would work in real life. So the key to this process was really convening a cohort that was diverse in setting and size and population, even level of primary care integration. We really wanted to ensure that the change package guidance would be applicable across kind of the full spectrum of primary care. So we were able to select 7 primary care agencies. A majority of them were federally qualified health centers, but we also had like a patient-centered medical home. We had a behavioral health authority that was co-located within a health center. So just a lot of different diversity and variation there so that we can ensure, again, that the change package was applicable across the spectrum of primary care. Throughout the learning community, participants received 14 months of targeted and responsive training and technical assistance. Here, the keys were that we really wanted to make sure that it was multimodal and multi-method. We focused on both clinical, organizational, and data-led components of the change package. And our TA approach here was really designed not only to support the practical realities of trauma-informed primary care implementation, so to support all of those learning community participants in whatever challenges or barriers they were facing through their trauma-informed care implementation, but also to really identify the strengths and weaknesses of the change package so that we can strengthen it during refinement. So we wanted to see where the change package was working, where it wasn't working, what points we might need to bolster or supplement to make sure that the ideas and the principles that we intended were resonating in the way that we wanted them to. So here you'll just see kind of a listing of all of the different types of activities that participants experienced as a result of the learning communities, a lot of individual but also cohort calls, webinars. There are some organizational self-assessments and performance monitoring tools, and I'll talk about that later, as well as virtual focus groups and both clinical and implementation data collection. So I want to just give some very, very high level look at some of our implementation data here. This was using one of our tools, which is called the organizational self-assessment. And what was really kind of heartening for us is that we see that sites demonstrated increases across all domains. So that's really good to see. One thing that's important to note here is that the organizational self-assessment is really not the best tool for assessing things on an aggregate, so you can't really see too much in this chart here. It's really a performance improvement tool that we put together to help an organization engage in really a self-reflective process around identifying the things that are specific to becoming a trauma-informed organization. But what we can see here is that there is a fair amount of variability across the organizations, which likely kind of indicates that they all had different starting places for this work and experienced different amounts of change depending upon the item. We can also see here that change concepts 1 through 3 are fairly similar with respect to baseline and follow-up. So that might suggest that some of those aspects of trauma-informed care were already fairly well established, like very early in the time frame. So again, this is a very high scope tool here, and it has much more utility on an individual basis. But I just wanted to show a quick snapshot because it is kind of a critical practice improvement tool that learning community participants had access to, and is a kind of key feature of starting this trauma-informed care implementation journey within the change package. So I also want to call folks' attention to the PMT data here, and this is another implementation tool that we use throughout the learning community. This one is a lot more concrete. The questions are very directed, and then they're combined with concrete indicators that map to trauma-specific action so that teams can really track their progress towards becoming more trauma-informed. So here, again, we see a lot of organizational variability among both the change concepts and the items within the change concepts. But in general, sites show the most growth on change concepts 1 and 5. And it's also important to note that the baseline mean scores here across the change concepts for the PMT were much lower than those in comparison to the OSA. So for the final version of the change package, and in response to a lot of the feedback that we got during the learning community, we actually combined the tools into one, and we feel that that just better helps teams to really match their organizational self-assessment results to the trauma-specific areas or actions necessary for change. And then we've created a nice little kind of template to really create an action plan so folks can clearly and concretely kind of outline steps, assign responsibility, and really move this initiative forward. So we also collected clinical data as a component of the learning community. We worked with our external evaluator at Iteration Evaluation to design a clinical collection or data collection process. And our focus here was really trying to ensure that data collection would be as minimally burdensome as possible. So we really focused on as much as possible on really using data that sites would already be collecting. So we are still in the process of analyzing all of the clinical data and drawing some analysis from that. But I do want to talk kind of briefly about the target population and then what we're seeing kind of preliminarily within these target populations. So again, I want to stress that we focused on making this process as minimally burdensome as possible. So our target population encompassed adults 18 to 64 that were Medicaid recipients, trauma identified, and had a health metric on one of the 5 values that we use, which were depression, smoking, BMI, A1C levels, and blood pressure. So we asked each site to enroll 30 folks. So we tried to keep it small, again, so it would be manageable, but so that we would still be able to kind of extrapolate some results at the end. And we had a total of 211 patients enrolled for the clinical data portion, and they enrolled between December 2018 and February 2019. So we got to follow them for a decent amount of time. And again, we're still working on analyzing all of the results, but at the conclusion of the project, preliminarily, patients receiving the trauma-informed care pathway through the project that were at risk for one or more of the metrics that we identified demonstrated improvements on 4 out of the 5 metrics. So that's really promising preliminary data. I think a big portion of this movement is really making the connection between these trauma-informed approaches and then actual movement around health outcomes. And this is kind of our first stat at really standardizing and codifying a way to do that. So again, within the change package, there is guidance and templates and documents around how to collect information and data to demonstrate the impact of your trauma-informed care initiative. So that kind of wraps up phase 2, and that brings us to kind of the final phase, which is the new version of the change package that we're so excited to release and provide access to. We learned so much during the learning community that we were able to kind of revise and strengthen and bolster the change package before its eventual release. So we did things like we added a lot of more forms and processes, more checklists. Another big thing was vignettes and tools to actuate the guidance and the principles that were outlined in the change package, we got a lot of feedback from our learning community participants that was kind of contradictory. So in some areas, folks wanted it to be more prescriptive, and in some areas, folks wanted it to be less prescriptive, and that's always a very difficult kind of balance to hit. But I think we did a good job at packing the change package with a lot of tools and resources to give folks the choice and some flexibility on how they implement certain things, and then also just continuing to really underscore the idea that many of these actions in one change concept may impact actions in other change concepts. So giving folks permission to not do things in a completely linear or sequenced way has gone a long way in the way that folks kind of engage with the change package content. So another few areas of improvement that I think are really important to highlight, we really focused on strengthening the screening guidance within the change package. From the outset of this project, we've gotten so much feedback and input about how the field is hungry for concrete guidance around trauma screening. So the change package identifies 4 approaches for trauma screening. It provides clear guidance on how to respond to patients, and then it also outlines options for how you adapt your care to meet your patient's needs and strengths based on the results of that trauma screening. We also really try to include more information on cultural responsiveness and resilience. Those are such kind of key partner items or topics that really bolster your trauma-informed care implementation. So we made sure that we added diversity, equity, inclusion language into all of the change concepts. We created a diversity, equity, inclusion specific training plan with some resources and change concepts too for workforce development. And we also did the same around resilience, in addition to kind of adding information on family and consumer involvement and community partnership throughout the change package. We also added guidance on data and CQI, so really creating some support around how to choose what data to check, creating templates and tools to make sure that you're outlining a process for continuous quality improvement, and then making sure that we integrated some data-specific goals into all of the change concepts to really underscore how important and consistent of a process that data and CQI needs to be. We also did a lot to the change package in terms of increasing usability and navigation. So we created kind of this compilation of components that show up in all chapters of the change package just to really help ground folks in what type of information they're receiving and how to use it. So the action steps, goals, and implementation tools are available that support each change concept. And then within each change concept, there are also key considerations to help you assess if you would benefit from taking any additional planning steps prior to implementing the action steps. And then there are also checklists, quick tips, sample scripts, and those sorts of things that offer additional strategies to really equip users to execute the change package principles. So another key thing that we included here is that we integrated a lot of case studies from the learning community so that we could provide some real world examples of ways that agencies were actually implementing and executing the guidance within the change package. So one important thing here is, or one important kind of reminder here is we think it's really important to read the entire change package first and then kind of sort out where you want to start. And then these little smaller subcomponents kind of help you to determine how to navigate and point you into tools and things to align your actions with your goals. So this is just a quick example of how each of the chapters are organized. Each section really outlines the action steps around that specific change concept, and then the change concept goal, so kind of the ideal state that you're driving towards. And then you have your implementation tools right there, which are designed to kind of bridge the gap and kind of guide your actions towards meeting those goals that we've outlined within each chapter. And just some quick information on why you should use the change package and why it's important. And I think it's just like, this is really a compilation of the most current and forward thinking that's available right now. And it really provides some concrete operational guidance for a very nuanced process and an overall pathway to create a trauma-informed practice. So in addition to those kind of areas of improvement that we talked about before, which kind of illuminate very concrete trauma-specific actions and activities and how to do so, overarchingly, this is a really comprehensive tool that a team or an individual or an agency can kind of use wherever they are on their journey around trauma-informed care implementation to guide and provide support and equip them with the tools and the strategies and the processes that they need all in one place. So I just want to provide some information on how to access the change package, and we can certainly make sure that we're sending out links and things and all of the follow-up information. But we did create a public website that houses the change package, and the website has links to download a interactive PDF of the entire thing, but the site is also a kind of blended learning resource center, and it has summaries of each chapter, and it has the downloadable resources and tools for all of the change package inclusions. So the website is really just another easy way to comprehensively access the whole thing. The change package is really jam-packed with a lot of links to tools and resources to help you really execute the principles and guidance that we've outlined. So for a lot of folks, the website is the best way to kind of click through so that you are engaging with the change package content, but then you're also really quickly and easily able to look at some of the tools and start to conceptualize how you might use them. So I am going to finish up, but I just want to reiterate that, becoming trauma-informed is an iterative process, and we never truly arrive. There are always improvements to be made. So the change package was really designed to provide some structure and process to a historically cloudy process. Throughout the many steps of this journey, we really encourage you to use the change package, continue to revisit the change package as its tools and resources can really help you at whatever point or iteration of this journey that you're on. Now I'm going to turn things over to Kathy, and she's going to speak to her agency's on-the-ground experience kind of testing and using the change package for implementation. Kathy?
Hi, this is Kathy Orton. Welcome to all. I'm glad you're all being attentive. It's a little difficult because I can't see anybody. But thank you for Sade for laying the foundation, and certainly the welcome from Dr. Leon. So let me give you a little bit of background on who is Zufall Health Center. We are a federally qualified health center, so we receive funding from Public Health Section 330. We serve 6 of the 21 counties in New Jersey, and we're in the upper northwest section. So it's a kind of suburban, urban, some areas are not that very densely populated, but they're still not defined necessarily as rural due to the population densities in New Jersey. So we actually have 8 sites. We have both medical and dental sites Some of the sites are co-located, and others, the dental is separate from the medical, just due to location space. We actually have a medical van and a dental van as well, so we are out in the community rather than people always just coming to our doorsteps. And we're very, available, friendly, Sunday, 7 days a week, on-call services and all of that, if patients need us. So we essentially offer primary care, adult, women's health, prenatal, pediatrics, and then we have dental, as I had mentioned, and we also have behavioral health at all our sites. Just about a year ago, it's now almost 2 years, we introduced integrated behavioral health services. So the social workers who are providing counseling to our patients are immediately available for short visits, and then determinations are made how much more counseling people will receive and the services that they need for their behavioral health. We also have Ryan White funding. So last year we served about 40,000 patients, which came to about 140 visits. So we applied when the RFP went out for becoming involved in the trauma-informed primary care learning community. We are definitely concerned about the well-being of our patients, but our application did highlight that we were concerned about our staff. We have a very challenging population. About 50 to 60% of our patients are undocumented. It's a very diverse population, highly Hispanic, from various both Central and South American countries. So we've always been sensitive to our patients, but it's not as though anyone at the site other than myself have had introduction to trauma-informed care. So you could change the slide today. We can get a little more. Okay, so essentially we did develop a core committee, our core implementation committee, which is recommended in the change packet. And we did start at step 1, which was essentially what are the strategies, and doing the organizational self-assessment, doing the performance self-assessment that was also requested to be done. And then they had a tool available called the environmental assessment. So it looked also at our physical layout of our sites. What were the colors? Do we play music? Do we have plants? Are there restroom facilities? Is the parking sufficient? Things that are give an orientation of a comfortable space to be coming into without any excessive stressors. So we looked at that as well. Go ahead, Sherday, we can move on. So essentially, our first entry in was initially working with our staff. And so we brought the information to an all-staff meeting, which at that time we were doing quarterly, and we showed a webinar introducing what is the term trauma-informed care mean, how do you go about recognizing it in your patients, a little bit about how do you respond when you have difficult behaviors or triggers do get set off in patients. So just to be assured everyone was on the same page, understanding the same terminology, which was new to folks. We also, with the staff meetings, we essentially this past year had 2 retreats. The trauma-informed care did shift both the format and the content of our staff meetings. Formally, we were meeting quarterly. The staff meetings were about, be assured you sign your timesheet correctly. These are the number of days off you have, your vacation days, and how you can use them. what we did was a half-a-day retreat in February, and then we did another half-a-day retreat in August. And so previously the meetings were going from 3:30 to 5 quarterly, and we actually dedicated an entire afternoon to these retreats where we provided lunch, we had snacks, all the staff was involved, and it was very diverse. We didn't, well, the first retreat, the providers met separately, but in the second retreat, the providers and the support staff and office personnel and the medical assistants all met together, and behavioral health staff. So we actually had talked more about what is trauma, what types of trauma are there, there's episodic trauma, there's developmental trauma. So people had a good scope of understanding any patient potentially has had trauma and has underlying histories or present issues. But we were also very sensitive knowing that our staff too come from backgrounds that have had trauma, or definitely within their family and friends, they have concentric circles of having been exposed to trauma. So our meetings, these retreats, were focused on communication skills. We actually did scenarios on, if a patient comes to you in a particular manner or style, how you do relate with them, knowing that there's an underlying issues going on for the patient. And so people had opportunities to practice with each other. People had an opportunity to dialogue with how to handle specific situations. So we made it, the retreats were extremely interactive. They were not didactic sessions where we were talking to our staff. We wanted our staff to engage with one another, and we did satisfy that. So the other thing we did was we set up a series of, every about 6 to 8 weeks, we have an intranet for just the Zufall staff to have access to. And we have little, they're like upbeat messages about, motivational interviewing, or, what's a good approach to address a patient who is under considerable stress. So just sort of things to focus on and work with each other. And I mean, one of the small successes, we've had a lot of success with what we've introduced. And one of them is we would hear staff saying to each other, that's not a trauma-informed approach. You're not communicating in a trauma-informed style. So we enhanced awareness, and we also gave practical skills and guidance for how to be trauma informed with our patients and with ourselves. This wasn't just a one-way street, how the staff related with each other as well. Okay, we can go on to the next slide. Okay, so these are a list of things that we actually had done. One of the big changes is that every job description now has a statement in it saying, we are trauma informed. You as a staff person have a responsibility to be trauma informed. We, at our initial interviews, our initial telephone interviews with people who are applying for positions with us, we actually ask them, are you familiar with trauma-informed care? It's not a, it's not a plus or minus for the continuation of their being considered as a position. But we also ask them about, do you have self-care plan for yourself? How do you take care of yourself, knowing that you can be exposed to considerable amount of stress in the environment that we're working in? So let's see, I talked about our 2-day retreats. We also now have incorporated trauma-informed care into our orientation. Every month we have an orientation for new employees, and the behavioral health staff, the director specifically, does a program on what is trauma-informed care. So they're coming in knowing what our language is, what our definitions are, continuing to keep everyone on, similar similar footing with the awareness of trauma-informed care. We began to introduce having a daily breathing bell at all the sites. One of our site managers were able to transmit it over the telephone, usually about 10 o'clock or 3 o'clock each day. We call it the breathing bell, and we just allow everyone to take, a minute. The bell is hit 3 times, and it's like just to relax for a minute, just to breathe, stop, have a little bit of space for self-care, slowing down the day for just a very specified period of time. We also reviewed our policies and procedures, and we wrote descriptive. We actually wrote a policy for trauma-informed care, and we also looked at particular policies. One of the policies we looked at and certainly had concern about was when someone comes late for an appointment. The policy was written in such a way, okay, well, if you're 10 minutes late, then we're not going to see you. We actually changed the wording on the policy to make it much more, consider the circumstances, learn from the patient, were they stuck in traffic, did one of their children get sick, get a bigger picture rather than just being so rigid. So that we did some policy changes in that regard. We're just, it's kind of, we have a loving care approach at Zufall, but we've actually just heightened the awareness of it. How do we say things to people? How do you respond? At the front desk, we've had additional front desk training about receipt of patients and feeling a comfort level. We also did a really brief little survey asking particular patients, do you feel listened to? Do you hear that you're supported by our staff? And basically, everyone was favorable in that regard. So we're continuing on with the process. Our core team was expanded, and we're also continuing to meet on. We're pretty fluid. About every 5 to 6 weeks or so. We didn't want to make this. We didn't want to necessarily, be really rigid with each other. We kind of wanted to practice what we were preaching, and we did that within the core committee as well. The other thing I want to emphasize is I know there are various concepts, but we found once we did our organizational self-assessment, we came up higher in areas that needed to be addressed than others. So we prioritized what we were working on based on what we saw our individual needs were. So it wasn't, the change packet has a lot of latitude, then it's not one size fits all, and this is the way it has to be done. There's a lot of room for fluidity. So let's see, is that it? I think that's it, isn't it, today? Do I have another slide? I don't think so, do I? Oh, here we are. And you're certainly welcome to contact. I know you're welcome. You're welcome to contact both of us, right, today?
Yes, absolutely. Happy to take any questions or calls around the change package, how to access it, if you're interested in getting some technical assistance on it. I'm the main point of contact here at the National Council, so I can certainly triage and address all change package requests. Dr. Leon, did we want to open up for questions at all?
Of course. And well, first, thank you, Sharday and Kathy, for this excellent presentation. This is a very important topic, and we could talk forever about trauma-informed care and all the experience that you have and that you have acquired through this process. It's also very interesting to see how this initiative came to fruition, and it's really, really nice to have one of the public housing primary care grantees participating in this initiative. So thank you so much. Sharday and Kathy for this. We are going to start our Q&A session. If you have any question for our panelists, please make sure that either you type your question in the question box, or if you dial in through your phone and you would like to verbally ask a question, just use the raise hand icon and your line will be unmuted. And before we have some questions, I just want to ask the audience to please complete the post survey questions. That is something that we need as a national cooperative agreement to provide services and make sure that we are providing the right training that you need at your health centers. We also would like to announce that we are going to have our national conference in June 2020. So you can find more information on our website at www.nchph.org. So do we have any questions?
Yes. Our first question comes from Valerie Coughlin, and it's for Kathy. Which staff comprises your committee?
Excuse me? Once again, I just didn't hear clearly the question.
It says, which staff comprises your committee?
Okay, so it was our chief medical director. Her name is Dr. Rena Ramirez. Our chief operating officer, Fran Palm. Our dental director, our director of human resources, our director of nursing, one of our pediatricians, our director of behavioral health. We had an AmeriCorps staff person when they were with us here. And we also had one of our social workers. And then most recently we've added, we recently hired a psychiatric nurse practitioner. She's joined the team. And we've hired, and also we have a physician assistant who's on the team. And we also had our director of our Ryan White program on the team. So it's a little more upper level folks, but the enthusiasm was amazing. I mean, people's interest in, wanting to learn is what is trauma-informed care, and I was the primary facilitator for our meetings, and yes, we'd have an agenda, but our staff just took off with it. So I don't know, that gives you a little bit of detail on who was on the committee.
Just to piggyback a bit, there is some guidance within the change package based on kind of our consultation experience and our approach that outlines some key categories for inclusion on a core implementation team should you start to convene one.
Great, thank you, Kathy and Sharday, for that information. Any other questions in the queue?
Yes, this comes from Jasmine Bravo Rosas. Do you guys have a care package for the employees, not necessarily for the patients?
When you say a care package, this is a change packet. I'm going to clarify that. A care package. What is the definition of a care package? I want to be assured I'm answering the question correctly.
Kathy, I believe that in one of your slides, and I'm just guessing, you mentioned that there were some concerns for the staff, and probably the person would like to know if there is if you have any policies or any recommendations, on how to address these issues.
Well, we have procedures in, how to work with difficult patients. We don't have like a manual or something that we provide to our staff there was some discussion, and it could surface again, about people creating their own self-care plan and kind of monitoring themselves. How are you doing with your care plan? But we didn't formalize something for the staff, so in that
Okay.
regard.
Thank you, Kathy. And Sharday, anything that you have seen for staff? Any reference?
Definitely. So two of the change concepts are specifically focused on staff. Change concept 2 really focuses more around kind of education and training around trauma-informed care. But change concept 4 is really around kind of secondary traumatic stress and compassion fatigue and how to help staff manage. So there are a lot of key tools in there around how to support staff in building their own self-care plans, as well as trauma-informed supervision as an approach for managing staff engagement and monitoring staff satisfaction. So the staff perspective, I think, is definitely a huge piece of this. And there are kind of 2 avenues for you to get at that through the change package.
All right, thank you. That's very helpful. Thank you so much. Any additional questions in the queue?
Yes. Yes, this comes from Kuala Kafidi. How did you manage educating medical providers and staff in a busy clinic setting, and how often?
Well, like I said, we use specified time blocks. We were most fortunate we had support from our CEO, and that we could set aside a half a day. We did it this year twice a year. So, and then, they have access to the intranet for, reviewing these little snippets that we gave them. The providers in February had a provider retreat because our chief medical officer is very astute to provider burnout. And, that certainly ripples out to staff burnout, other than just the providers. So they had their own retreat with undivided attention for concerns that they address. And we also, we have an open door policy here at Zufall. It's very transparent. If somebody is troubled, or there was the other I forgot to mention because it wasn't on the list, but we actually started like a debrief group. I think it's meeting once a month, particularly for the behavioral health staff. So we've set aside time, one day a month for them. We have a psychologist on staff who's part-time, who, now, they used to have debriefing sessions for their patients, but now it's more focused on their own needs and their own potential frustrations. So we've prioritized that, how critical this is for the health and well-being of our staff.
Great. Thank you, Kathy. Thank you so much. Any additional questions in the queue?
Yes. This comes from Emily Kane. Did you find that being trauma-informed affected how you developed employee-based policies?
Well, yeah, we took into consideration a new approach to, like I was saying, like we used to say, oh, a patient came in 10 minutes late to an appointment. Well, then they had to reschedule an appointment. We changed the format. We changed the approach. We didn't use the clock as the indicator that they weren't going to be seen. We would assess the situation, see how demanding, how many if there was room in a provider's schedule to actually see the patient that day, even if it wasn't the provider they were originally scheduled to see. So we would do more assessment about a situation instead of sticking to hard, fast rules. And so it's a matter of, it's almost just creating a human tone of not being hard and rigid according to rules and regulations, but to being, somewhat flexible, adaptable, resilient to, what is it that the patient needs. It's very patient-centered. We are a PCMH. All our sites are recognized as a patient-centered medical home. So,
Thank you, Kathy. Thank you so much. I would like to be very respectful of everybody's time. Is to one, do we have one more? I believe that we can answer one more question if there is any additional questions.
Yes. One small question from Eddie Sissons. Besides the slides, will the packet be shared?
Yeah, we can definitely, I'll put together a little blurb and some information and share with Dr. Leon so he can send out in the webinar follow-up materials.
Excellent. Thank you so much, Arte, and we will be very honored to send all this information out to specifically to the attendees, all the resources, including the slides and information about the trauma-informed primary care will be on our website at www.nchph.org. And I would like to once again thanks Sharday and Kathy for this excellent presentation. Thank you so much. Please join our mailing list and receive HRSA updates, information on funding opportunities, on resources and services, and upcoming webinars. Visit our website, nchph.org. You will find all kinds of resources, webinars, monographs, publications, interactive maps, newsletters, and information on our annual symposium. And this one is going to take place in Virginia, Alexandria, Virginia, in the month of June 2020. You can also follow us on social media, and if you have any questions, you can contact any of our staff members. Once again, Sharday, Kathy, thank you so much. And if there were any additional questions and your question were not answered by the panelists, we are going to make sure that they receive the question, and we are going to send the responses to the attendees. Thank you so much, and have a great afternoon.
thank you so much. It's been a pleasure.
Everyone. It was great.